Welcome to this short lecture on jaundice. So jaundice is essentially a yellowing either at the skin level or at the sclera, which is the white of the eye. Jaundice is usually a complication of an increase in bilirubin. This is a type of byproduct from the breakdown of heme, which is a breakdown product of part of hemoglobin of red blood cell. Now, to develop jaundice, you need to have approximately 2.5 milligrams per 100 mils of blood, of bilirubin in your blood, to develop that yellowing aspect. Now, because you're white of the eye, it has a greater propensity to take up this bilirubin, so that's probably the most sensitive part, but you can also see it on the skin when the bilirubin levels increase enough. So the first part of this lecture, or this mini lecture, will look at how bilirubin is normally metabolized in the body, and then we'll have a look at how when it breaks down, you get these jaundice looking features. So what needs to happen first? So in your systemic blood, we have red blood cells. Okay, so red blood cells will be traveling through your blood. Now, red blood cells, as you are aware, they live for approximately 120 days. And when they get old and worn out, they lose their shape, and then they can start to get stuck in very narrow blood vessels. So the most common place where you'll get the destruction of red blood cells is going to be in the spleen and in the liver. And this is going to be incorporated with macrophages in those particular areas. So both the macrophages, which would predominantly happen in the spleen, but it can also be macrophages called Kupffer cells in the liver, can also do that role. So a person who was to have their spleen removed, their liver can still do this particular process. So red blood cells would come, and essentially the macrophage within the spleen, let's use the spleen as an example, would destroy the red blood cell. Now, the red blood cell, some of it would get, so the globin part, the globulin part would be used for further proteins, so that would be used for proteins somewhere else, broken into amino acids and so forth. And the other part, or the heme part, okay, the heme part is broken into iron, and then iron would be taken to the liver to be reused. And then the part that we're looking at today is the bilirubin. Okay, so bilirubin is the first main derivative that we want to look at as the heme starts to break down. Now, the bilirubin, if it's in the blood of the spleen, it would get added to by what we call an albumin molecule. So the bilirubin would sit on the albumin molecule or the albumin protein within the blood vessel, and that then would be transported, this together would get transported to the liver. Now, because the bilirubin is fat soluble, so it can't dissolve in water, it needs to be taken by that albumin molecule, which is in that blood all the time. Albumin is produced by the liver, but it's always in your blood. And so it binds to this albumin molecule, and it will be transported now to the liver. But please bear in mind that the bilirubin at this point is what we call unconjugated. Okay, so I'll just label it acronym UC. So this unconjugated bilirubin is now taken to the liver via the blood to be further processed. Now, as we said, this unconjugated bilirubin is fat soluble. So it's going to get processed through the liver, okay? And essentially what it's going to happen as it moves through is it gets conjugated, which a water-soluble molecule or glucuronic acid is added to it. And so that then makes it conjugated. So this conjugated bilirubin can now safely pass into the area of the liver that it allows it to excrete or get rid of its waste product. So this conjugated bilirubin, okay, I'll call it CB, conjugated bilirubin is now processed through into the gallbladder or into the cystic duct. So we've got the left and you've got the right hepatic duct meeting the cystic duct, and then it goes on the common bile duct. So this system is going to take bile down into the duodenum. So we've basically got the unconjugated bilirubin, which is fat soluble. It's coming to the liver. It's being conjugated with the addition of glucuronic acid. It's now become conjugated bilirubin, and it's been excreted out of the liver through those hepatic ducts, meeting the cystic duct with the gallbladder. This thing here is the gallbladder, and then taking it down the common bile duct, so it's going to move down here like so, where it enters the duodenum. Now within the duodenum, it's now going to be further processed by the bacteria in your gut. So what happens there is they're conjugated, so as it enters, it's conjugated bilirubin, but it's going to be essentially oxidized and made back into unconjugated bilirubin. So it's going to be made back into a form of unconjugated bilirubin. Okay, and this is what we call urobilin. This is urobilin. It's been oxidized by the bacteria. It's now unconjugated bilirubin, but not so much the same as it up here, slightly an oxidized version of the conjugated version. So what will happen now is probably 85% will be continued down the intestine, whereas about 10% will be put back into the blood. So it will be absorbed back in the intestine. So this 5% will go back to the liver. So 5% of that unconjugated bilirubin, or the urobilin, will be put back into the liver, which then will go back through again, and that does another cycle back into this and so forth. So that's that 5% of the 10%. The rest of it will go back into the blood, and this, remember, is the unconjugated urobilin, and it will get essentially processed in the kidney. So the kidney will then modify it slowly, and it will make it into urobilin. So that urobilin will then be processed in the kidney and excreted out through urine. And that urobilin will be essentially the yellowing of the urine. So that's going to be the reason why, so the unconjugated aspect is going to be the reason why you get that yellowing aspect of your urine. And then finally, the last segment, or the 85% of that unconjugated bilirubin, which has been modified by bacteria, will be further oxidized and made into stercobilin. And so this essentially will be excreted out into feces, and this stercobilin is what gives you that darkening colour in your feces. That's the browning colour. The stercobilin is the browning colour of your feces. And that essentially is the process of bilirubin. So just to recap, we start up with the red blood cells. So we have normal aging red blood cells, or you could have an increase in destruction of red blood cells, but in any case, the macrophages have to process the red blood cells to get rid of the hemoglobin. The hemoglobin is broken into globulins, which is then processed as proteins. The heme portion, the iron's sent off for further processing, but the bilirubin is quite dangerous. So you don't want to be just putting bilirubin into your blood. So it gets further processed. So firstly, because it is fat soluble, it will bind to albumin within your blood because it can't dissolve in the plasma. So that unconjugated bilirubin is fat soluble. It will be taken to the liver, where it's now processed or conjugated through glucuronic acid. Now that with a number of enzymes, and then that will get pushed through into the bile system, and that will be excreted down into the duodenum. Here, the conjugated bilirubin will be oxidized and further modified by the bacteria Now 10 to 15% of that will be absorbed back into the blood. Now 5%, or about half of that amount, will get further looped around in the liver, and that will be cycled, whereas the other 5% will be taken to the blood, where it will be taken to the kidney. And remember, the urobilin or ogen will just be made into urobilin. And that urobilin will then be excreted as urine, and that's what gives you the yellow in colour of your urine. And then finally, that 85 to 90% of the now unconjugated part in the intestine will be modified or oxidized further to stercobilin, which will then colour the feces brown and will be excreted. Okay, so we've done the metabolism of bilirubin. So let's move into now a pathology where there is excessive amount of bilirubin in one of its forms. So I put a table up, and these are the three main causes of why you would have an increased amount of bilirubin in your blood. It would be either a pre-hepatic cause, so before coming into the liver, intra-hepatic cause, a problem with the liver itself, and post-hepatic causes, problems with getting the bilirubin or the bile out of the liver. So let's firstly just go over the process, just so we have all the rows in the right order, and then we'll move into the examples. So the first thing that needs to happen in the normal process of bilirubin metabolism is the RBCs have hemolysis. So there's hemolysis of the red blood cells, which would lead to the breakdown of heme, and that gets processed into unconjugated bilirubin, which would get processed with albumin. But essentially, this step is the unconjugated. So unconjugated bilirubin. And from what happens here is it gets processed through the hepatocytes into conjugated form. And then that finally gets excreted into the bile to finally the feces. So the process is you have red blood cell destruction, which is at a normal level. We have the hemolysis, the heme, so we've got the iron goes to one side, the globulin goes to the other. The heme creates the biliverdin into bilirubin. It's unconjugated, so it's fat soluble, needs to jump on board with albumin, and then it gets taken towards the liver. This unconjugated bilirubin gets processed through the hepatocytes, which conjugates it, and then that conjugated bile gets taken to the intestines to be taken and excreted through the feces. So that's the normal process that occurs. Now, what happens with pre-hepatic? Some examples of pre-hepatic causes is where you have excessive amounts of hemolysis. So this area is excessive. And some examples of what would cause excessive amounts of hemolysis would be thalassemias, sickle cell anemias, or risk factor incompatibility between the mother and the child, and that would lead to an excessive amount of destruction of the hemoglobin. So this would be excessive, but all this process would be normal, and we would come to the unconjugated amount. But because the hepatocytes, now the hepatocytes, they're essentially normal in their function, but they get overloaded. So they kind of back into here. So too much bilirubin's been produced, so too much unconjugated bilirubin's been produced. It goes to the liver, which is normal, the hepatocytes are normal, but they just can't keep up with that amount. And so it backs into this, and so what we end up with is an increase in blood levels of unconjugated bilirubin. And so that would cause the levels in your blood. So you'll become jaundice, but the type of jaundice would be unconjugated bilirubin form. Okay. Now moving down here, you would have probably a normal to maybe slightly darker colour feces, because the processing all through here is the same. It isn't changed, so you're going to still have the same colour, maybe a bit more because you've still got extra or higher amounts of unconjugated going through, but most of the problem is it backs back and you're going to have an increase in unconjugated bilirubin. Now when we move across to the intra-hepatic causes, this would be problems with the liver itself, so the hepatocytes are damaged or dysfunctional itself. This could be also called hepatocellular dysfunction, okay, or hepatocellular jaundice. So the most common ones would be probably hepatitis or cirrhosis. And so this is going to be normal. You have the normal hemolysis in the body, okay, so that's not a problem, and this is going through like so. So this part of the process is okay, but the hepatocytes are dysfunctional. So the hepatocytes are dysfunctional. Therefore, what happens is both, this is not being processed, so you'd have an increase in unconjugated bilirubin, so that part will be increased, but also the amount that you do, the amount of conjugation that you do carry out, so there'll be still some conjugation, it wouldn't process through into the feces so well, because not only are the hepatocytes damaged, but also the bile caniculi and so forth is damaged, and it can leak out into the blood pretty quickly. So the conjugated can be up as well. So the conjugated could be also up. So in intrahepatic causes, both these levels are up, which would both lead to jaundice. So the jaundice could be unconjugated and conjugated forms. And so the colour of the feces is probably going to be variable. It could be light, could be dark, or could be fairly normal looking. So that's the intrahepatic causes, that's within the liver itself. Finally, let's move to, I'll change colour to purple, to the post-hepatic causes. So this is where you have generally problems with the transport out of the liver. And a good example of that are stones, gallstones. So again, the hemolysis would be normal, so there's no change there. And the processing through is going to be okay, so there's no problems with this part. The unconjugated amount is going to be normal. And the hepatocytes function is normal. So it will pass through, it will conjugate it, but the problem here is, well, should I say that? The problem here is the excretion part. So there's going to be a blockage here. So the stone kind of puts a blockage between the bile secretion into the intestines. So that would cause a build back into here. So the unconjugated level is going to be built up. So the conjugated level would be increased because we've processed it normal. The conjugation has occurred in the liver because the cells are normal, but the excretion out is built up. So it will come back into the liver and then build up into the blood. So the conjugated aspect would be increased. And so what that would do to your feces is it would make it light coloured because you're not getting any conjugated bilirubin into the feces to be made into urobilinogen to make the colouring through the amount of stercobilin. And so the conjugated will be put into the blood, and therefore the blood also causes the urine to become darker. So that darker conjugated bilirubin, because that, remember, is now water soluble, that's going to go and be excreted through the kidneys, and that will make the urine darker colour. So that's essentially all the types of, all of these will cause jaundice, okay, so they'll all cause the person to go yellow because the bilirubin is built up. We've just gone through how they do it differently. Some are caused by increased conjugated amounts, some are a mixture of both, or some are caused by an increase in unconjugated. So I hope that has helped in you understanding what causes jaundice, but also the normal processing of bilirubin metabolism.